Good morning or afternoon, depending upon where you are, and welcome to the Fall Online Clinical Educators Forum. I am Alicia Feist of the Arizona College of Optometry, and I serve as the chair of the ASCO Clinical Educators Forum, which is bringing you this event today through the support of the Clinic Directors Administrative SIG. Today's topic is engaging today's student. It's something we're all keenly interested in, and we're fortunate to have some faculty who are willing to share some of their expertise and tips in this area with us today. I'd like to acknowledge the Clinical Affairs Committee, Dr. Don Godey, Dr. David Hall, Dr. Basant Labib, Dr. Michael McGovern, Dr. Amy Moy, and Dr. Greg Waldorf, as well as the SIG liaisons who serve on our committees. Thank you to our 2022 OSIF co-chairs, Dr. Valerie Kattouf of ICO and Dr. Amy Moy of NECO, who both volunteered to steer this program and effort. Thank you to each of our presenters who have taken time from their busy schedules to be here and share their knowledge with us today. In addition, thank you to Ms. Carol Brubaker, our Clinical Affairs Committee staff liaison at ASCO, and Ms. Sarah Lau at ASCO for helping us behind the scenes today. They've all been instrumental in bringing you this forum. Lastly, we want to thank our on-site OSIF liaisons for helping us spread the word on your campuses about this important program we are bringing you today. For a few requests, if you're watching as part of a group, please make sure you have an attendee sign a sheet and send to Ms. Brubaker via email. Please take a moment to double check that you're on mute, and please remain on mute throughout the duration of the event. We'll be accepting questions on the chat during our Q&A portion of the program. And please keep your camera on if you are a presenter or moderator. The meeting will be recorded today for posting on ASCO's YouTube channel, which is accessible through the ASCO website. And Ms. Brubaker will send a SurveyMonkey to link to each registrant shortly after the conclusion of the program. And please complete this survey so we can utilize the information to better prepare for future planning. We have 3 excellent sessions prepared for you today and 2 moderators who will do our hosting. So without further ado, let me hand things over to Ms. Valerie Kattouf.
Thank you, Dr. Feist. I appreciate it. Today I want to thank you all for being here, and I'm going to share a couple of housekeeping notes. I just want to add that you can put your questions in the chat anytime. They'll be answered at the conclusion of the presentations, but we love to have that kind of interaction. And now we're going to just move on to our forum. We have wonderful speakers here today from 3 ASCO schools and colleges. These speakers were invited on this panel because of their expertise in engaging with students in the classroom. So we're going to start with our first speaker, Dr. Anu Lau. And Dr. Lau has been with the clinical faculty at SUNY since 2016. Prior to SUNY, he served as clinical faculty at Johns Hopkins School of Medicine and the Ohio State University. Got to say, go Bucks for that. He was the chief of the ocular disease service at Ohio State and graduated from the Michigan College of Optometry. And he followed with a residency in ocular disease at the Ophthalmic Consultants of Boston, New England College of Optometry. So Dr. Lau's been to a lot of our institutions. He's an attending in the primary eye care service and the glaucoma service and teaches ocular disease clinical procedures lab. He's the instructor of record of the ophthalmic lasers and in-office surgical procedures course and takes a role as an optometrist in surgical care as an elective. He's a member of the American Academy of Optometry, the American Optometric Association, the Optometric Glaucoma Society, and is board certified by the American Board of Optometry. Dr. Lau is also the chair of the Environmental Safety and Infection Control Committee and runs the glaucoma micro-credential program at the college. So all of that is so impressive. And I know you're going to be equally impressed with some of the innovative ideas that Dr. Lau is going to share with you today. So I'm going to let him take over and do a really interesting demonstration that I know a lot of you will be able to apply to your own coursework.
Thank you, Dr. Kattouf. Thank you for inviting me. I want to thank ASCO as well. I think this is a great forum. You know, one of the things that I really love about this is the fact that, you know, we can essentially learn from each other. So what I'm going to demonstrate today is essentially how I use an iPad when I lecture. And I think that it was sort of the technology that I picked up during the pandemic. So during the pandemic, I used my iPad to lecture to students, and I made my lectures a lot more Zoom friendly. So here at SUNY, essentially what we do is that, you know, we use Zoom as our streaming platform. We use Microsoft Office, so things like PowerPoint, Whiteboard, you know, Outlook, and that type of thing. So that's the software that we use. And then really what I added to it is I brought my iPad. So essentially, as you can see here on the screen, I'm lecturing via my iPad. And I'm sure this setup is very similar to your setup in your institutions. We have a podium with a PC at the podium. That podium PC is connected to the screen, which you see behind me. And we also have a video camera and recording equipment so that you can actually hear my voice. So that's, again, a setup that I think most of you guys have in your own clinics. But you may notice that I'm holding an iPad, right? And I'm walking around my iPad. So what I'm going to talk about today is how I sort of set up my iPad so I can lecture, both to the benefit of folks that are in-house, so those folks that come to class, and those students that are at home watching it remotely, or those who watch it on their own time. I don't know how it is in your institution. However, for my class in the third year, I have about 20% of the students actually show up to class. Out of a class of 100, we have about 20% show up in class. I have around 50 that show up on Zoom synchronously. And then I have the other, of course, 30% that watch it on their own time. In terms of the setup, so what I tend to do is I log on to Zoom just as I normally would on the PC that is in the lecture hall. Then I log in on the second time on my iPad, and that's what we're seeing right here, okay? With Zoom, it allows you to log on twice, so I don't need a separate login or anything like that. I believe some of the other platforms are similar, so if you use something like WebEx and such, I believe it's similar. If by chance it is not, what I would say is I would have your IT department maybe make you a separate login ID so that you can log in once on the computer on the PC, and then log in secondarily on your device, whether it be a tablet, like an iPad or a Microsoft tablet. This is my own, iPad, so I don't own stocks in Apple or Microsoft or anything like that. This is just what we use at SUNY. It's not a very expensive iPad. I got it maybe 3-4 years ago. It still has a home button, so it's not a very expensive piece of technology, and I think it's quite easy to use. In terms of setup, I'm going to show you here real quick because I am on my iPad right now. On the Zoom screen, this is what it looks like on the Zoom screen. Just a couple of words for the wise here. You want to, on the top here, you can see that I don't have my video sharing on my iPad or the audio sharing on my iPad. And the reason being is that, as you know, as I mentioned earlier, in the classroom, we have a video camera that's on me, and I have a mic that's on me that actually gets projected and recorded. So you don't want to have it on the iPad as well, because if you do, you're going to get some reverb. And then if you're walking around with the iPad, your camera is going to be moving all over the place. So you don't want to make anybody dizzy. You also want to have your rotation lock on so that you can rotate your iPad or whatever device that you have, and the screen doesn't rotate because, of course, you don't want to make anybody seasick or anything like that either. So as I said here, I essentially log on with my on the PC, and then I log on again with my iPad and I share screen. So you can see that my screen is being shared right now. From that, I go back to my main home page. I go on to my PowerPoint presentation. Now we use 365, as I mentioned, Office 365. So all of my lectures are saved to my OneDrive, and I can access my OneDrive using the PowerPoint app. So again, here I am in my lecture. So I want to kind of demonstrate a couple of things, maybe the pros and cons of lecturing via an iPad. So I'm going to show you how I do it. So as you can see, or you might be able to see, whatever you're seeing on the screen here, you guys are seeing on the main screen up there. So folks that are in a lecture hall will see that behind me. And then folks that are online will see exactly what you folks are seeing online, just as you are right now. So let's see how to navigate the system. And again, I'm using PowerPoint, but I'm sure the other ones are very similar to use. So when it comes to advancing your slides and moving your slides, you actually just use your finger and you just swipe, right? So, and going back, you swipe the other way. So again, very easy. If you ever used an iPad or an iPhone or any type of smartphone in the past 10 years, or if you're on one of the dating sites, I mean, it's the same motion. It's very quick and easy to go between slides. So again, that's really one benefit that I think it's kind of quick and easy to use. The other thing is that I don't know if you guys do this as well, but I like to see what the students online see as well, because the vast majority of my students, only 20% of my students are in class. So the vast majority are looking at my lectures online. So I go on to our site here and I see what the students see. As you can imagine, I mean, I'm sure you guys been to some CE programs where you have a speaker and the setup is relatively similar, and the speaker essentially might be pointing to something using a laser pointer. But for those folks at home, you really can't see that, right? So what I tend to do is that every single time I make it a point that instead of pointing to something when I'm in the classroom on the screen, I actually point to it on my iPad. using the laser pointer feature. How do you do that? It's actually pretty easy to do that. You just have to push your finger down and the pointer shows up. And you can move this around just as you move your finger around. So it's really quick and easy to do whenever you need to do it. And like I said, it shows up on the screen so those folks at home can see it as well. You can also buy one of these things which kind of mimic your finger. You get a box of like 3 or 4 for like 15 bucks. It's the same idea. You just kind of push and hold, and there you go. You know, your pointer shows up, pretty quick and easy to do. What's another benefit? I'm sure you guys in glaucoma have seen this slide. It's a structure function slide. This slide, of course, can be very overwhelming if you're trying to talk to your students about structure function on the right eye, for example. This is a very busy slide, right? So how can I make this easier for students to pick up on? Well, I can actually, with the same motions that you're familiar with your iPhone, I can actually zoom in on a feature. And here I am. Now I'm looking at the right eye. So I can talk to my students saying, okay, hey, you know what? Have a look right over here. There's an inferior notch right over here on the heat map, which correlates to the deviation map. And then you can kind of move over and say, look, this is how it looks like on the visual field. So you're relating structure and function. So again, it's a nice way to, go over a very busy slide. I'm thinking you guys who teach, let's say, biochemistry or something like that, if you're talking about the Krebs cycle or something, you can actually go in certain parts of it to break that information down to make it a lot easier for those folks, again, in-house, but also those folks that are online. Another thing that's kind of helpful as well is that, when it comes to pictures like this, right? So in a picture like this, there's a lot of things going on. This patient obviously has some severe diabetes happening. So if you wanted to zoom in again on certain areas, certain points, you absolutely can do that. The other thing is that, if you wanted to maybe point out particular features, you can actually draw. So if I'm going to be here saying, okay, you know what, like this is what a Circinate ring looks like. I can even change colors. So let's say, okay, these are what cotton wool spots look like. It just makes it a little bit easier for you. So again, those folks that are in the classroom and online are actually seeing the exact same thing. It also works on videos as well. So I'm going to go ahead and show you a video here in a second. One other thing I want to mention is that besides pictures, you can do it with text as well. And this is a great example of, if you're showing a text and you want them to really pay attention to a particular passage in the text, you can highlight that for them. So let's say I want them to really focus on this paragraph right here. Everybody wants to know what's going to be on the test. Again, it's very quick and easy that you can do it right then and there. Does it work on videos? Yes, it works on videos as well. So here's a video of a hydrus happening. I can zoom in on the video if I wanted to zoom in, if I wanted to point out where the trabecular meshwork is. So this trabecular meshwork, scleral spur, and ciliary body. You can also draw on here. So let's say I want to pause this for a second, and I want to talk about that. Hey, guess what? Here is your ciliary body. This right here is just scleral spur. This is the pigmented trabecular meshwork. And the surgeon is going to do is they're going to go ahead and put the hydrus in like so. So I'm going to show you that's how the hydrus is going to look when the surgeon puts it in, and then I can play the video, and there it is. It's relatively easy hopefully for the students to kind of see. So again, it's a nice feature that way. And then also, when it comes to things like using a whiteboard, obviously there's a whiteboard behind me in the classroom. I'm someone that does like to draw a lot. And if students ask questions, I do like to draw it out if I don't have a slide on it. As you can imagine, in a 100-seat lecture hall, if I draw something on that whiteboard, it might be really small to see if you're sitting towards the back. Or if you're watching this online, it might be really difficult to see. We do have a whiteboard app. So I'm going to go ahead and actually give you a real-time example using the whiteboard app. The whiteboard app is something, it's a Microsoft app. So if you're already on the Microsoft family, you can go ahead and download that app. So I'm going to give you sort of a real-world example. So I've had a student, and this student was lecturing actually to a classroom, and a student actually online asked me, when we think about things like PRK versus LASIK, and he was confused about the fact that why on PRK you can is better for thinner corneas versus LASIK. Why in LASIK are you limited? So essentially what I did is I actually drew it out for him to make it a little bit easier for him to understand. So I kind of drew out here, that's the epi. I'm going to put here stroma, like so. And again, I'm doing this in real time, so you guys are following along here with me. And endo. All right. So this is the cornea, right? And let's pretend that this patient's cornea is essentially, just to make math easy, I'm going to say that this cornea is, move this up here a little bit. I'm going to say that this cornea is 500 microns in size. And in order for us to make it, make sure that our procedure is safe, I want to make sure that I have a bed of around, let's say 250 or 300 microns to make this thing safe, right? So if I have a LASIK flap, which is, let's say, 150 microns thick, like so, then all I have to work with is around 50 microns to ablate. And if you're thinking about 15 microns per diopter, we're thinking in the ballpark of around 3 diopters worth of correction that you can do. However, if you're doing, PRK, all you're really doing is that you are kind of cleaning off that epithelial layer. So now you have all of this tissue to work with. You have about 150 microns to work with. So you just tripled the amount of treatment that you can do. So again, by drawing this in real time, you can draw it really quick and easy for your students. Not only do they see it, those folks online, but the folks that are in the classroom, can see it as well. So to kind of finish off here, what I'm just going to quickly mention is kind of the pros and cons of using tablet-based technology as you're lecturing. So as you can see, I think the pros are, it's more dynamic. You can zoom in, zoom out. You can draw onto your slides, which is really fun. You can draw onto your videos and such, which I think is really fun. You know that the pointer feature and everything that you do on your iPad is also going to show up for those folks that are online and those who watch it later on. And the whiteboard is something that I find that is really, really fun and easy to use. What are the cons? Well, the cons are, there's a few. So people asking me about the chat function, question and answer. How do I deal with that? Because as you can see, everything that is on my screen is what you're seeing on the screen up there. So if a student is writing a chat, it's not easy for me to actually look at it right over here. Right? So the way that I get around it is that I actually, on the podium, I actually log on to Zoom, as I mentioned, and I open the chat function at the podium. So I can easily walk over the podium, just kind of take a peek to see if there's anything in the chat. You could also make breaks within your lecture. So maybe every, 8, 10, 12 slides, you have like a question break. It allows you to maybe, take a sip of water and also walk over and see if there's any chats. Other ways to do it is you can have a student who is in-house so that the students that are there with you monitor the chat and they put their hand up and saying, Dr. Lal, we have a question in the chat. And that way I can walk over to the podium, have a look at that question, hopefully answer that question. The other drawback, presenter mode. So, as you can see, there's no presenter mode on here. So whatever you see on your screen is what you see. So how do you get around that? If you're someone that uses presenter mode a lot, I would say that there's a couple things that you can do. What I do is I actually write notes and I keep this on the podium. So every so often I just kind of walk over and make sure I'm covering the points that I need to cover. You can actually print off your PowerPoint presentations with those presenter notes in there. And then again, keep that onto the podium, walk over there, make sure that you covered each point before you, kind of swipe and go to the next. Cost, well, as I said, this is a relatively cheap iPad. I bought this 4 years ago for around, $300 to $400. So I'm sure there's fancier ones out there. But I think the cost is actually relatively low, considering your IT team probably even has this technology there that you can ask them to potentially use. And then the learning curve. Well, this is something that I started doing during the pandemic that I carried over. I got a lot more comfortable doing it during the pandemic. I thought about how I want to make a lecture that is online friendly, and now I'm carrying that same information to my in-classroom activities. And like I said, I'm actually a lot more comfortable now lecturing with the iPads as opposed to the little clicker that we've used in the past. I went through that obviously really, really quickly, and I hope we have some questions, but I just wanted to leave you with my email address. Definitely give me a shout. Happy to chat with you. If there are things that you think that I can do better, please let me know. I mean, this forum is fantastic for the fact that we can share ideas. So definitely please keep me in the loop. I do want to thank ASCO and the organizers of this event to ask me to speak today. So with that, I'm actually going to go ahead and stop my screen share and hopefully answer a few questions that some of you might have.
Yeah, so I'm going to go ahead and read the questions to you, Dr. Lau.
Sure.
Let me see if I can get the chat up here. Here we go. Okay, first question. Are there any advantages or disadvantages in terms of functionality between the different technologies, like an Android versus an Apple iPad, if you could even use together?
Yeah, no, that's a fantastic question. So I've only used Apple iPads. That's something that I've been using for 10 plus years. I have used a Surface before as well, and the functionality is very, very similar. But I have not used an Android product. So for those of you who don't know the Surface, that's a Microsoft product.
Yeah, so like I have a Surface laptop, so I could basically just use that screen in tablet mode. Oh, that's great. I was just sitting here thinking I needed to buy an iPad, and I guess I know.
Yeah. So I've used the Surface, and it's very, very similar. I mean, there's small differences, but again, once you get used to it, it's super easy.
That's great. That's a good tip. Okay, next question. How easy is this to use when using some other interactive technology such as Top Hat? Some people use the different clicker questions and things like that. I think you mentioned that before.
Yeah, absolutely. So for some of those types of technologies, if you're doing polls and other things like that, I usually actually walk over to the podium and I actually run my poll from the podium, because then I can see the results, and I'm the host at the podium. I'm a co-host on my iPad, so I can see the results. I can manipulate things, and then I can just go back to my iPad for the lecture portion. So yes, it's relatively easy to do.
And I guess in closing, one of the themes that we touched on during our last presentation was just kind of the engagement in students, whether on site or off site. Do you have a preference of where students are? Do you find that this kind of meets them halfway so you get engagement with both? So share your reflection on how it is.
Sure, yeah, no, this is a great question. I know we've talked about it ourselves, and I've even talked about it with some of my colleagues here. It's a great question because I prefer, obviously, my students to be in the classroom with me, because I look at their faces and I can see if they're nodding. I think I'm making sense. If I see confused looks, then I may slow down. So I do like the back and forth of a classroom setting. However, this is a function that we have allowed our students to view our lectures remotely. This is how it is since the pandemic. So what I had to do as an educator is to kind of make my lecture a lot more remote friendly than I ever had before. It's one of these things where, my class happens spring quarter of their third year, right before they go on rotation. And I obviously think that my class is the coolest and funnest class. I mean, it's the ophthalmic lasers and in-office surgical procedures. Why wouldn't you want to come for that? However, these kids are right ready to go on rotation. They've been on campus, I guess, for 3 years. It might be harder to get out of bed, maybe because my class is Friday morning. That could be it as well. I'm not sure. But yeah, I would like to see students come back a little bit more. I think you lose some of the peer-to-peer when you're online. I remember if I was too embarrassed to ask a question to my professor, I'd ask one of my classmates, like, hey, I didn't get that. Can you just go over that with me? Plus the social aspect, go to coffee after, going after class and stuff like that. I think you miss some of that social aspect. But I think students now learn a little differently. Their social interactions are different. So it's weird for me, but yeah,
I'm with you.
That's how it is.
But I like that you're not fighting it. You still have an option to keep them there, but there is only so much you can do. So in closing of your terrific presentation, there was a comment from an attendee that said you could probably use your phone, which I think you did mention to us yesterday, Dr. Lau, as well, since it's Office 365 or apps on it.
Absolutely.
I use PowerPoint and OneDrive on my phone. And in that line, someone else had asked the question, can you please share a list of apps that you utilize? So maybe you could type in the chat just some apps that you utilize, and we could share those with anyone who wants to capture that.
Yeah, sure. I mean, I can tell you even right now, it's the whiteboard, PowerPoint, and Zoom. That's all I pretty much use, honestly.
Great. Good. Well, thank you so much. That was terrific and definitely so usable. So we want to thank Dr. Lau. And now I'm going to hand things off to my co-moderator, Dr. Moy, who's going to introduce her colleague at her institution.
Thanks so much, Dr. Kattouf, and thank you for that very helpful presentation, Dr. Lau. Our second speaker is Dr. Benjamin Young. He is known at NECO as one of our very innovative and humorous professors, as you will soon see. And I am so pleased that he's with us to share some of his strategies with us today. Dr. Young is an assistant professor at NECO in the Department of Primary Care, where he is the instructor of record for the Principles and Practices of Optometry 1 course. He also facilitates seminar and laboratory classes focusing on ocular disease, clinical reasoning, and technical procedures. Dr. Young sees patients as an attending at the NECO Center for Eye Care in Roslindale, where he provides eye care services to a diverse patient population and precepts second, third, and fourth year optometry students. Dr. Young received his BS from the University of Connecticut in 2013 and graduated from NECO in 2017. After graduation, he completed a residency in ocular disease at the West Roxbury VA Medical Center and obtained his fellowship at the American Academy of Optometry. His scholarly interests focus primarily on educational research, specifically the gamification of education, multi-platform content delivery, and multimedia design. In his free time, Dr. Young enjoys playing piano, hiking, and spending time with his family. Dr. Young, I'm going to turn it over to you to share your presentation, The Gamification of the Classroom and Its Effects on Engagement.
Awesome. Thank you so much, Dr. Moy. Thank you for having me here at all. I'm just going to talk briefly about this concept of gamification in education. It's a really broad topic, so we could talk a long time about this. I'm just going to kind of hit the high points and the principles behind what you could even utilize this in the classroom, and what that would look like or could look like. So when we talk about gamification, the really core component is using badges, points, or leadership boards to create a rewards-based experience. So there's a couple of key concepts here that you have to hit on in order for it to really be considered a game. But I would like to make the argument that we are already playing a really complicated game with our students already. Higher education is intrinsically gamified. The challenge that you give them is to pass the course. The reward is that final grade that you give them. You outline your rules in the syllabus. You give them meaningful choice by allowing them to participate and perform with various activities within the course. And then they can also have this sort of illusory attitude. I'll touch upon what that really means in a bit, but it's basically the students buying into the educational process and being part of that kind of quote unquote game. So why might you want to add like an additional element to that if you're already doing that? Well, research has shown that if you have a specific gamified component to the course, can actually improve students' motivation and engagement with the material. So that's kind of where the majority of the research lies. There's also some evidence to say that it improves their academic performance as well as their even inquisitiveness into the scientific process, motivating the learners to kind of engage as part of that scientific inquiry. So I would say there's a lot of benefits here. And a big thing that we kind of think about is that engagement and the motivation to get students to be a little bit more involved with the course and the material that we present to them. So how might you do that? Where would you begin? The first part is to think of a meaningful challenge. So this kind of French philosopher came up with this idea of like the greater the obstacle, the more glory in overcoming it. And that's true for a lot of things. So you want the challenge that you give the students to be large enough for them to feel intrinsically rewarded by completing it, but not so difficult that they are defeated straight out of the gate. One way in which you can like improve their motivation to then complete this challenge is to show them their progress over time. And that's showing them some sort of leaderboard, showing them the points that they have, or any sort of way that they can track their progress. That reward is a really key component to any sort of game that is developed. And we think of those in kind of in two different buckets. One is the intrinsic reward that kind of comes from within the student. So that's that social connection they may experience by working as a team or against each other even. Having a deeper understanding of the material since they're engaging with the material in a different way. And then also having that sense of accomplishment by winning the game. So that's all something that comes from within themselves. Now, these extrinsic rewards are things that we as instructors assign to the game. And that's where it comes into play when we're thinking about things like extra credit, trophies, badges, rankings on the leadership boards. Anything that we create as an extrinsic reward and can be quite powerful in increasing motivation and engagement with the game. So the first thing you really want to do, figure out your challenge, figure out what you think the reward should be, but then outline the rules in your syllabus. You need to make it very clear what the rules are and make it as fair as possible for everyone who's going to be participating. And it's really important in the syllabus to indicate whether or not participation as part of this game is voluntary or compulsory. A big part of allowing someone to kind of be part of this game that you're playing is to give them a sense of meaningful choice. And there's a couple of different ways that you might do that. One is to have a specific activity that allows the student to kind of go on like a choose your journey scenario. So this might be applicable something like in third year. If you say a patient has glaucoma and you have the students pick out a specific treatment plan, and then you have an outcome based upon the specific treatment plan that they choose, then you can say, this is what happened. What are you going to do now? And you can have different outcomes depending on different ones that or different treatment plans that they have. And it can really go down a road depending on what point you're trying to make. So that would be an example of like one specific assessment or activity. Or you can just have like a really large assessment or activity that takes place throughout the entire course. And I'll show you an example of that at the end here. Other thing you can do is focus on quality as opposed to accuracy, making sure that students can kind of harness that sort of creative energy when they're participating in the game, and then also offering them a range of ways in which they can interact. So this illusory attitude is something I alluded to before. And what that really means is it's a voluntary attempt to overcome unnecessary obstacles. And what that really means is that there is a opt-in process that everyone has to do when they decide to play a game. And I think the easiest way to think about this is like baseball, right? If you're going to play baseball, you can't just run around the bases and then get to home plate and win, right? You have to hit the ball has to be grounded, then you have to tag first, and if someone tags you out, then you're out of the game. These are all inherent obstacles that are created as part of the game when it was incepted. And so in order for you to play and accept that those inefficiencies are going to take place, you have to opt in. And that's what this illusory attitude is talking about. So what is a way in which that we can increase this illusory attitude within a game that we create as part of our course? Well, I would argue that the biggest and easiest way to do that is to assign it as extra credit. It inherently means that the students don't have to participate. You can make it really clear that they can pass the course, get an A without participating in this game. And that allows the students to have that sort of agency that participating in the game is something that they chose to do. You really want to avoid this kind of like what I call the fundatory flaw, because research has shown that when students perceive these rewards for this game as a means of control by the instructor, it actually decreases their intrinsic motivation to participate in that activity, but also in the course as a whole. So one example I want to show everybody is what I started in fall of 2020. I called it the PPO RNFL. And what that really is an extra credit activity that encouraged attendance in lecture, integration of material, and I had the students kind of compete against each other in order to get the highest number of points for, like I said, extra credit. Participation was totally voluntary, and I developed a point system to allow them to track their progress over time. This is just a diagram showing exactly how I did that. So have 5 different students, put them into a team, and those teams were then grouped together to compete towards a league. So you are individually earning points for your team, but then that also is adding together to the other team scores towards those leagues. And the leagues are also competing against each other. It sounds a little complicated when I say it like that, but it's actually not. It's pretty simple at the end of the day. So the way in which that a student would win is by having the most number of points within their team or their league. So while everyone else was learning how to make sourdough bread, I learned how to use Photoshop during the pandemic, and I came up with all these different posters for the students that allowed them to have some sort of sense of identity with their team. So we have Team Billie Eilish, and I gave them this poster that they could see, and whenever it is they got first, second, third, fourth, fifth, sixth place, they could see exactly where their poster was, and that allowed them to identify where they stood within the ranking. So there's two different parts of this here. They could increase their motivation and engagement by trying to win as a team, or they could try to overall help their league to win. And I think both of those increase the engagement and the motivation overall. There's multiple different ways that students could participate in this in order to earn points. One was just answering Turning Point lectures, questions in lecture. Now, Turning Point's kind of rebranded recently. They're Point Solutions now. But the best part of this technology is that it works remotely. So if the student isn't actually in lecture, but we are zooming it out to anybody who's at home watching it, they can still participate. And it's pure participation. So if they got the question I asked right or wrong, they would still get the points for their team. They could also submit a multiple choice question before every major assessment. So we have 4 in my course. There's 2 major quizzes, the midterm and final. So they have 4 opportunities to submit a multiple choice question. And if it was valid, a valid question, valid answer, they would get 2 points. But then I would pick my favorite from the list of questions, and then I would put one of those on the assessment and allowed the students to really kind of feel like they have a little bit more agency and control of what's in the exam and feel a little bit more engaged that way as well. So then I assigned that 10 points. One final way that we allowed them to participate is by having them answer challenge questions as a team. So all 5 students would get together. They would have 10 minutes to answer 10 challenging questions, and they would get 1 point for every question they got correct, but they would have 1 point subtracted if they got any question wrong. So it's kind of like SAT rules in that sense, where if it was really encouraging accuracy and speed, making sure that they felt really confident that that was the answer before they chose it. So the leaderboards were the key part of this. I sent them out every week, allowing the students to know exactly where their league stood with, or their team and league stood within this competition. Told them exactly how many points that they had, and if they were in first, second, third, fourth, fifth, sixth, and we had 30 teams total. And I had a list of what all the teams were and their placements as well. In addition to that, I told them the ranking of their leagues, which were separate. And then I would send out an email with these leaderboards, kind of just taking on the voice of like a horse racer announcer, being like, we've got the Blepharitis Brigade in first place, followed closely by the Hyperopic Horde. And it was just kind of a fun way to make the students kind of feel involved with the activity and give the whole like assessment activity like a more lighthearted feeling at all. Kind of trying to, in a sense, increase the illusory attitude that the students might have and their perception towards this game. So when the semester was over, we gave the students a chance to have an anonymous survey. We gave them a de-identified number that they used to then answer these questions. And it was mostly aimed at their engagement and their motivation to be part of it. And overall, we have a pretty overwhelmingly positive response. The largest one saying that the students had a strong desire to be part of the winning RNFL team or league, and that they got to know their classmates better as a result of this game, which made sense. It was fall of 2020. The students were isolated kind of in their rooms. They weren't really meeting their classmates in a way that they probably were beforehand. So this was just another avenue, putting them into teams, kind of making them work together. In addition to that, we use a modified version of the active learning health professions scale and actually teased apart which parts of this that they found engaging. And one of it was saying that they felt like they had a better understanding of the course material overall, and also the fact that they had to integrate concepts together. And I think that came from mostly the challenge questions and the multiple choice question submissions that they had. So this is a game I did in 2020. I actually still do this. I'm actually doing it right now as part of the fall 2022 course. And it's really gone really well. It allows the students to integrate this information in a way that they don't otherwise. It's a good way for me to give them more practice problems, practice questions, way to apply the material. So this is just one example. You can do it on a much, much, much smaller scale if you wanted to just have one activity that then you would have students compete against each other, or you could have it something as large as this. This here are all the references I used in order to create this.
Thank you, Dr. Young. We actually have some questions here. Dr. Redfern said, would it be great to have a tracking system or game to track sales in the dispensary by students? That would be actually pretty awesome.
That's a great idea. We've actually tossed around ideas like that here at the clinic that I work at to try to track like how many patients are going straight from the exam room to the optical. So that's funny because that's something we've talked about as well.
Yeah. And then Dr. Harewood is asking, is this activity done for extra credit or incorporated to their grade as per the syllabus?
So this is purely extra credit. So the students, I tell them at the beginning of the course, you can be totally successful in this class without having to participate in the RNFL. It's just another way to help you kind of integrate the material.
Yeah, so could you talk a little bit about using it on a smaller scale for core teaching concepts where all students might participate in some way? Have you done that?
Yeah, so I've seen this done in multiple different ways. One is that having students submit multiple choice questions just in isolation and not have kind of the rest of the components, and just say like however many valid questions that you can submit that then your classmates answer, you can assign points that way. One of our colleagues at NECO does that, and he uses the technology Peerwise in order to keep track of the points that they have. And that's a much smaller scale. Or you can even just do it as part of one class. We've had faculty members also just play a game of Jeopardy inside of the course, which allows them to kind of use the information, compete against each other there as well. And then sometimes we'll just do it as part of one class where we have the students answer questions and then they just can follow along and see like how they are doing compared to their other classmates within teams as well.
Mm-hmm. Yeah, all great strategies. There's also a question of what % of students have opted in.
Oh, that's a great question. So the way I actually framed it as part of the course is that I'm saying, I am putting you into these teams and I automatically do it at the beginning because I teach first semester, first years, like nobody really knows each other. And then I say, if you don't want to participate in this, that's totally fine. I put the ball in their court and just say, you don't have to participate in this at all. So there's not necessarily an opt-in specific system, though that could be a really successful strategy as well, and say, how many people actually want to participate, and then assign the teams afterwards. And that might be easier to do if you already know the cohort that you're working with.
Mm-hmm. And how much extra credit would you advise for this kind of approach?
So this is something we went back and forth a lot on. We didn't want it to be too high because we didn't want it to really affect drastically their grade. So I would cap it around 2 to 2.5% of the overall grade. I think it's a high enough incentive and reward to have students actually want to participate in this game, but it's not too high to really affect the way in which that you're assessing their understanding of the material overall.
Mm-hmm. Makes sense. Dr. Reimer is suggesting for a clinical skills bingo card. That would be fun as well.
That's great. Or even like you could just use badges for something like that. Every time that a student does well with a specific type of clinical skill, then you can have them track like their progress over time by just assigning them badges. You know, we use stickers all the time for like 6-year-olds in like a pediatric clinic. We know how effective they are. So badges are really just a gamified version of adult stickers. And it's been shown to be quite effective.
That's right. As Dr. Kachuf said about Peloton achievement.
Yeah.
Yeah, I said it with Beachbody programs. I get that little badge. I'm so proud. So silly.
Whatever works, right?
Right, that's right.
And the last question, Dr. Harewood had said it'd be interesting to see which students by demographics participate and if it correlates with their overall academic success. Do you have any thoughts about doing any kind of comparisons in the future?
Yeah, absolutely. A lot of the survey that we did here was mostly just like, did you like this at all? And is it worth us just even doing? So it was mostly engagement and motivation, but we have all of the data. We can absolutely go through and say, these are the students who either participated the most, these are the ones who participated the least, did that change the outcome in terms of their final grade in the course or specific assessments? I think there's a lot of questions that we can answer with the data that we already have, and that's a really good avenue to go down.
Thank you so much, Dr. Young. I think I'm motivated now to go out and buy stickers and try something in clinic. But thank you so much for your excellent presentation. And then now I'm going to turn it over to Dr. Katouf again for our last speaker.
Very good. Thank you, Dr. Moy. Thank you, Dr. Young. That was great. So our last speaker today is Dr. Kari Yoshiyama. Dr. Yoshiyama is an optometrist specializing in primary care and ocular disease. She serves as the Assistant Clinical Director of the UC Berkeley School of Optometry and teaches at all levels of clinical optometry from the first year through residency. She, prior to her time at Berkeley, Dr. Yoshiyama worked within the Palo Alto VA healthcare system. She served as an associate clinical professor at the New England College of Optometry and was the director of eye care services at Geiger Gibson Community Health Center. Her research interests include optometric education and utilizing teaching methods and technologies to enhance learning. She's been an invited speaker at the American Academy of Optometry, the Clinical Education Symposium, and at various associations of schools and colleges of optometry. And now here's Dr. Yoshiyama. She's going to share strategies in the delivery of remote education. And one thing I just realized in putting this all together is all three of you have the Dr. Moy connection with NECO. There's that in the history. It's in there.
Brings
So
us all together.
that's right. So thank you, Dr. Yoshiyama.
Good morning, everybody, or good afternoon, depending on where you are. I'm on the West Coast, so it's morning here with us. And I did want to just thank ASCO for inviting me, and also our two other amazing speakers. I learned so much from both of them, and I think some of what I'm going to talk about ties in a little bit to the ideas that they've brought forward, and I'm excited to bring some of their ideas into what I'm going to be speaking about and into the class as I go forward. So with that, go forward. So just like Dr. Laus had said with his course, we converted this particular course to fully remote. So it used to be 100% in person before the pandemic. And now we foresee into the future going forward forevermore in a 100% remote delivery. And there were a couple of reasons for that. This is a summer course that we run for incoming third-year students, and Berkeley is a 7-day-a-week clinic. And so, you know, there were challenges in students having class right before coming to clinic and such like that. And so this eliminated some of those barriers. But how did we keep it really interactive and to the core principles of it being about clinical learning and not so much about memorization, because these are clinical students. And so with that, let's just jump right in. So as we all know, living through the before times, you know, in 2020, when everything was rainbows and roses, and we didn't think about all of these things, you know, we always had in mind, you know, how we're going to engage, you know, with our clinical learners in the classroom. But then the pandemic started, right? And normally, you know, like I said, we're a 7-day-a-week, you know, full year-round program. So a lot of the strength of our program really is based on students being able to actually see patients and interact in that sort of one-on-one sort of way. So how do we convert that into something where they might not be in front of actual patients? So when the pandemic started, I think all of us learned that, you know, we had to do things a little bit differently. So I love this quote: "I'm always doing that which I cannot do in order that I may learn how to do it." And, you know, the pandemic came very quickly. California shut down sort of on a day's notice. And so within 24 hours, we converted our clinical educational program into a fully remote clinical learning program. And so I'm going to briefly touch on some of the things that I'm sure I share with so many of you on how we sort of dealt with that transition and what kinds of things that we pulled from that we actually now have incorporated into the curriculum on a full-time basis. So I think the first thing that we all learned when we had to convert to remote learning was that there was a difference between the synchronous type of learning that was sort of in real time versus asynchronous learning. And we needed to find a balance between those two that would optimize the clinical learning. And so this was just sort of, you know, the data that, you know, I had come up with. in that first week in the shutdown, we managed to put out 8 hours, of synchronous learning. And it was that first 24 hours where we were all downloading Zoom and, learning how to use the platform, to the latter weeks, in the shutdown where we were providing, up to 40 and 40 plus hours of synchronous learning. And so we wanted to, use some of that information and translate that into a more permanent type of clinical education. And how that kind of laid out during that time was a mixture of different kinds of learning components. And we tried to utilize some of these things when we were rebuilding the curriculum for this remote course. And that ended up being a blend between sort of grand rounds, case-based kinds of lectures, but really more like panels of doctors that had a lot of interaction and discussion so that the students could really see that in clinical care, as opposed to maybe purely didactic learning in the first 2 years, is less about memorization and more about utilizing your core knowledge to actually make decisions. And that the clinical world is often gray, and we'd like it to be black and white, but it's actually, a key component of clinical learning is to see these experts on a particular topic or a particular case actually debate the diagnosis and debate the management and treatment, and sort of introducing students to the idea of the thought process that goes along and that it's active. And then, of course, having the component of being prepared and really targeting the sort of learning that is based in evidence-based medicine, and correlating that to self-study papers and, an active journal club type setting where, we can actually talk about, the clinical research and how it applies to how it might change our outcome measures. And certainly telehealth in the sense that, we're involving real patient cases. And then, of course, it's important to have a variety, of different topics so that we can be well-rounded and expose our students to the breadth of the type of experience that we want them to be prepared for. So this was what we had targeted during distance learning. And, on a limited scale, during the summer of their third year, we try to pick the things that we think that are going to be the most useful to them, as early learners in the clinical system. But we change it up year to year. We have different speakers and different topics so that the cases remain new and it's still a really good learning experience. And it's kind of based on, what, we feel like is from the previous year, what things that we've gleaned from that particular class. And also it's good to have, a variety of different educational experts to come talk to folks so that they get a wide-ranging idea of the type of clinicians who are actually seeing the patients that we have in our clinic. So that's all fine and dandy, and we all did that during the pandemic. But then how do we translate that into our learners who are just making the transition? I'm talking about our second year preclinical students who are transitioning for the first time into summer clinic. So we have a summer clinical course that's before clinic begins. And it was always in person and it was highly interactive. We usually had 1 or 2 or even 3 doctors present. And we were mobile, we were interacting with the students, running things on the board, running back and forth. There was a combination of group activities and individual activities as well. And so how are we going to convert that into a remote platform and have that same level of engagement? And so it goes back to our earlier 2 speakers here. And again, I thank you for your wonderful ideas. But some of the things that, we weren't able to capture quite so well as the clinical laboratories. So, the hands-on practice, proficiency testing. At Berkeley, we have team care experiences where they actually go down into clinic in pairs and see patients first in 4s and then 3s and then 2s before they go into single exams by themselves so that they get a gradual introduction to the clinical learning. And so how do we approximate that? So one of the things that we instituted in the summer of 2020 was we took the incoming third year students and instead of having them transition back into clinical care after the shutdown, we delayed them for half the summer. So the 4th years went back to clinical learning, but the 3rd years we had what we call a preclinical boot camp. And that wasn't with real patients. They were simulated examinations on each other, but it wasn't just your preclinical testing and such like that. We actually had 2 exams in the morning, 2 exams in the evening, in the afternoon. Some of them actually were in the clinical space. We have a preclinic EHR environment that mimics the same EHR platform that we use in clinic, but it's not connected to the patient information system. So it's completely HIPAA compliant, and they can use it just like they would use the normal system, but with their own data. And we made each encounter, they were given a script and sort of like a tutorial on acting lessons so that they could really enact their patient. And we tried to match them up. So if we knew that a student had, say, slightly larger than average CDDs, then we made them a glaucoma suspect, and we gave images and things like that. And we gave them, instructions on, how to answer questions so we can approximate that. Everyone did a contact lens fitting and such like that, but without the pressure of being in front of a real patient, because they had, had a little bit of a gap in their preclinical education. And so that was how we prepared them, with the technical sort of aspects, but then how do we prepare them for the clinical thinking aspects? And I will say that the boot camp was really, really popular and really helped the students a lot. And so we have now incorporated that. We kind of moved the preclinical education a little bit further on in the stream. And so we now have time at the end of every 2nd year preclinic to have boot camp actually within the spring term. And that's a permanent part of our clinical education now. So now I'd like to talk about how do we enhance clinical thinking in our students in a remote way. And that was, I think, the bigger challenge for us. And so here's some of the things that we did, and I'd love to hear your questions or your comments on if you guys have done that, in your courses. Not all of our courses at school are remote. Some of them are hybrid, some of them are fully in person. It's just what we chose to do in the clinic. And because I'm a clinical administrator, we had a lot of latitude to change this as part of the clinical course and as part of the clinical education. So this course actually comprises 15% of a student's summer clinic grade. So it actually balances out, the clinical grade, and hopefully we make this a learning course that is both engaging and a good learning environment, but very low in stress. So hopefully it helps that transition into clinical care, and knowing that part of their grade is going to be buffered by this participation in this course, I think is something that is nice for the students as well. There's no midterm and no final, which, you could find controversial. It was an easy transition for us to do that. Why? There's no grading of a midterm or final. So that's really wonderful to have that. But it actually really goes along with the thought process, which is we really wanted to help the students bridge the gap between didactic, sort of the memorization kind of thinking, which, at Berkeley, our students are really smart and they can soak up information like crazy. But this clinical thinking was really about committing on the spot to, maybe a thought process out loud, which is kind of scary, especially if you've been remote for a long period of time. How do we instill the thought process that we are lifelong learners? And so what we do is for each case, and this is a case-based course, so we have instructors come in, guest lecturers, and I do some of the guest lectures as well, present to the students in preparation for the course, selected pre-readings. So it's not, the case is not, they're not coming into it blind. They know how, have an idea of what the case is going to be about based on the topics of the readings. And then they're asked to take a pre-class open book quiz, because one of the other questions that we come up with is like, how do you ensure that the students aren't collaborating on the tests when you're doing them completely online? And we decided it doesn't really matter because it really wasn't the memorization that was really important. We just wanted them to come prepared to class to be able to do the participation. And it's worked out really well. And then they come to the course, and all of the in-person activities is based on participation. So there's no real right or wrong answers, but it really enhances the engagement of the students, and kind of gets to the core of what we're trying to get out of the students. But at the same time, how do we balance the social interaction versus the individual commitment to an answer, like we would in clinic, where your instructor might say, "So what do you think?" The dreaded question of every clinical student. So the way that we did that was we launched 2 programs at the same time. So Zoom, which we're all familiar with, and then Canvas, which some of you may be familiar with, which is an educational platform that you can have quizzes and tests and things like that on. You can post videos and all sorts of other module learning type of situations. And we launched them simultaneously during class. And the beauty of that is that you can pre-program all of these to have your discussion or quiz questions come up during class, and they can be timed, which is really great. So the way that we do it is we present part of the clinical case, and then we ask the students a series of questions that they have to answer in Canvas. And we only give them about a minute to think about it and answer, to really get them in the mode of in-time clinical thinking. And then they submit that, and we can see in real time when they submitted it. So I can see that everybody has actually answered individually. And then we switch over to the group discussion portions of it. And in Zoom, of course, there's the nice function of having the breakout rooms. And so what you can do in the breakout rooms is you can preset the students into separate breakout rooms. And that means that, we can set like 4 to 5 per breakout room, and you can change it and have it preset so that there's a leader. You can designate a leader in each of the breakout rooms, so that when you come back, they can report on what the group's thought was. And we usually have them put that in the chat, because we found that even when we did this in person, there was some hesitation to raise your hand and put the thought process out there. But something about the Zoom platform makes it really easy for students to immediately type in the chat. And so you start getting this stream of the leaders putting in their answers to the clinical questions. And then it makes it really easy because their name is on them. Then you can just call on them one by one in the order that you want to present the information, and have it be really interactive that way. And then each week there would be different leaders in the groups. And so that also encouraged participation. So I'd like to just run through very quickly. This is not exactly one of the cases, but it's a topic that I speak on, which is glaucoma. So we would take some basic article like this one, the 5 rules for optic nerve head assessment, which is really great for early learners, and we would have them read that, take a quiz, open book quiz online, so they understood what the idea behind this particular case was going to be. And then we present a real patient case, and we ask the instructors to take real cases from their actual practices. So it really ties into, the students feeling like, they're actually participating in patient care. And then maybe we would present an interesting finding. In this case, we present the optic nerve head photos from the particular examination, and using the reading material and evidence-based learning, we ask the students then to answer a question on their own. And you can see that the questions are somewhat deliberate in being that there's not really one right answer. And it's basically, which one of these aspects of these optic nerve head photos is the most concerning for you in respect to making a diagnosis of does this person have glaucoma or not? And as you know, all of these things are really important parts. We picked optic nerves that have all of the different characteristics. So the students don't have one answer that they can just choose. They really have to think about, prioritize what's important and what's not important, and then answer the question being put into the Zoom groups. And then they sort of duke it out in their groups to come up with what they feel like is the most important points. And then they present it in the chat, you bring them back out, and then you call on them, the leaders, one by one, so you can have that discussion. And sometimes what that means is that it's just a cycle that repeats. So based on the questions that they ask or more information that they want, so say that they want a visual field or an OCT, you would present that data, and then the cycle would begin again with the next set of questions that you would have about how they interpret it and what that means, and does that change their diagnosis going forward. And, in my particular case with glaucoma, as you all know, glaucoma has so many different tests, and it would be really easy for a student to just say, I want all the tests. I want pachymetry and I want OCT and I want all of these things immediately. But we all know that test taking in real time takes time. And there's a cost or an insurance sort of, conundrum for some patients. So we throw in little things like that says that, basically this patient doesn't have insurance. And so you have to prioritize your testing, which tests would give you the most information, if you had to prioritize. And then we take them. And if they say, I think that because there was a disc heme, I think it would be important to have the OCT. Well, then you can present it. And I love Dr. Lau's iPad, because I could zoom in on this and I could point out the different aspects of this particular OCT, which belongs to that actual patient, and point out where on the RNFL deviation map it maps to where the previous disc heme was and what that really means, and such like that. Maybe they ask for a visual field and you can say, it's kind of clear. So if we had just had that, would we be really concerned about it? And you can provide all sorts of different data based on what they're actually requesting, and then talk about the relative benefits and the limitations of the information that they're gathering. In this particular case, you can see that just an IOP chart wasn't particularly helpful because it was never really in the range of where we usually think of as really high IOP. And then follow-up data. So, in this particular case, I'd show follow-up data and showing that, if we had decided we weren't going to treat, we were going to follow, well, this is the follow-up exam. Does that change anything? And we can see now there's 5 disc hemes in the same location. And we run through that and really talk to the students about that. It's in clinical care, you don't have to make the right decision on the spot, that sometimes additional clinical knowledge changes our direction, changes our diagnosis, changes our management. And that's actually part of the process. And it's not something that we should be hesitant about discussing with each other and, with, our colleagues as well. And here's just follow-up data on the follow-up visual fields, which we can now see has some defects. And really, so just in conclusion, having a remote real-time clinical thinking course that's remote pairs really well with a sort of in-person, like sort of boot camp experience where they do the technical and the clinical thinking aspects on, each other with actual cases, and then having actual patient cases that we talk to them about, with real data in real time, so that they actually have to make decisions. And I think probably the most important one for new clinical learners is learning that they don't have to be afraid, because there's usually not one right answer for clinical care, and that it's okay to change your mind during the clinical thinking and to collaborate with others. But that in reality, when you're in clinic, you don't have the benefit of going home and thinking about it. You have to make decisions in real time based on questions that you ask and testing that you do in real time. One last thing that I would point out is we actually look back during the time when we were doing remote learning for COVID to look and see how students perform with this level of remote learning. And what we really found was that, for the 4th years, obviously the 4th years had almost their entire clinical education, and they only missed a couple months. So it maybe is not so surprising that overall, that in all the different areas of clinical learning in clinic, that they performed as well or a little bit better with this more hands-on training that we had. But the interesting thing that to us was that the 3rd years who were using it as their introduction to clinical learning, actually, when they came back into the fall with their actual clinical patient care, they actually did significantly better than prior years. And that's what was one of the things that was a really pleasant surprise for us and what motivated us to incorporate that into our permanent clinical curriculum. And it's been working really well. So we've been doing it ever since the summer of 2020. So with that, this is my email in case anybody has any questions about implementation. And thank you again to ASCO for inviting all of us to speak. I hope there are some questions.
Yeah, so thank you so much, Dr. Yoshiyama. Before I start with questions for Dr. Yoshiyama, I want to open it up for anyone. If you have questions kind of just about all of these topics or questions for the other presenters, please feel free to type those in because we have a few minutes left as we go to wrap things up. So one of the comments, I know Dr. Yoshiyama, you made a comment about being able to zoom in, like Dr. Lau had said, on the iPad, and someone just made the comment that you can also zoom in on the PC. I know sometimes maybe our lecture setups are different in that way. I don't know if that was just a comment that was in there. But as far as questions go, for you, this is, from what I gathered, this is a kind of a coursework you do that is clinical teaching. That is correct, right?
Mm-hmm. Yes, and it's actually part of their summer clinic.
Oh.
So our clinic, so their clinical education, no matter if it's in-house or an external rotation, is part of a clinical course, and it's its own course. And so we have a lot of latitude to have this as being part of the seminar portion of their clinical experience. And so that's how we were able to incorporate it and make those kind of changes and sort of have it be tied in so that it was easy for students who had clinic right afterwards to get to clinic. Really, we used to have this course like pretty early in the morning so that the students could get off and then grab their equipment and then run down to the clinic downstairs versus the students who maybe didn't have clinic that day. And so there was a little disparity there, but now, everyone can either do it from their exam room. They can set up the exam room downstairs and stream the course and then immediately start, or they can be at home or traveling to somewhere else and they can also participate. The other thing that I didn't mention here is that along with, sort of the idea of the gamification and changing, the calculus on how students want to engage and make it something that they want to engage in. So then the question was, what do we do if somebody misses class, right? Because this is an interactive learning, right? And you can't make that up. You can't write a paper and get the same sort of clinical education. So we really want students to participate in it because that's where they're going to get their clinical learning. And so we really carefully designed the points-based system. It's kind of like gamification, only not so much fun. Such that a student could miss one full in-class participation and still remain within their grade. So like it could still get in the A range. And so that allowed a lot of things like, so you have, you have Mondays off and you wanted to attend a wedding and you didn't want to make that up sort of thing, then you had that latitude, you could just not come and there's no makeup for that. Of course, we work with students individually if something else comes up. But it was also really wonderful because sometimes if students were ill, but not so ill, that they could actually, do this from home and actually continue to participate and learn, which was really a nice side effect of it as well.
So basically what I'm taking is you did make this complete remote learning and you allowed
100%.
it to adjust.
We thought about hybrid, we thought about different things. And then when we looked at the data and we realized, and we did similar surveys with the students, we realized that we were doing a pretty good job like remotely and that we could just enhance it with more things that we learned from the pandemic and just offer it fully remotely. And like I said, not every course does it that way. In fact, I'm not sure if any other course does it fully remotely like we do, but because this is a clinical course, we just decided that it made the most sense for the clinical students to be able to do it this way.
So yeah, and it seems like I like, the way you said it works around your clinic schedules, their schedules, with some of your motivation there. We have a question here that Dr. Lau actually asked, how easy was it to get outside doctors from VA optometry, ophthalmology, et cetera, to participate in a course like this?
We don't have a lot of them participate in this case-based portion, but we continue to run the RCLs, the remote clinical learning. In fact, I have another one So I'm in charge of that program too. So I was the one who actually converted, the education into the remote learning. And so I built up a network of folks, and they just jump right in. I mean, I was amazed. Like I said, the first week was 8 hours, and by, 4 or 5 weeks in, we were churning out 40 plus hours of remote learning. And everyone really wanted to help, and they just jumped right in. And so by the end, I was able to pick topics because I was trying to balance the types of clinical education that we were presenting. So I would pick people in those topics from different places so that we could get like a panel of people having that discussion. And that's really where, I realized that students really like participating and asking questions in the chat, like much more so than they would like if you had a panel of really impressive doctors like in front of them. That could be a little bit intimidating, but also to see that interaction between the different people and presenting different data and having that change opinions was kind of how we recrafted this idea into the didactic course.
Good.
So that we could have that. But yes, the engagement was, and we even had private practice folks like, participating and such like that. So it was really wide ranging.
Yeah.
And so, next 2 weeks from now, I have another RCLS. We continued that in after clinic education, and it's completely optional. So we continue to do different topics. Like we had a clinical psychologist come and talk about, different difficult conversations to have with patients. We've had all sorts of different things that supplement.
Good. That's very interesting. So another question, when you do these discussions, you had mentioned kind of the absentee issue and allowing them to have one unexcused absence. But the question was, are these discussions available online? Or are they recorded should the student miss that and want the experience?
We don't do that because I guess the idea is that the learning happens sort of the surprise of clinic, because the patients don't come in with their diagnosis written on their forehead and asking, for just, please give me the treatment that's necessary. Sort of the journey that we all go on in clinical learning is getting to that point, and how do we make decisions at different points in time based on information that's coming in. And our worry was that if we just posted it and that students just did that portion, that it would lose the aspect that we were really trying to do. It's not about memorizing the case or trying to get into the doctor's head about why they made this decision or that decision after the fact. It was going through it with the students and supporting them in making those decisions in real time, and sort of figuring out like a choose your own adventure. Okay, we went down this path and we chose this, and this is where it ended up. Is that where we wanted to end up? Maybe not, but it's okay, because now we can go this way with additional information. And so we chose not to do that. And they don't have to go to any of them if they don't want to. But
I think that's interesting though, because by not taping them, you kind of made the motivation to be there and have that experience more like a real live clinic experience, which you're not going to tape and have again. So that's interesting. So I know it's about time for us to wrap up. I just want to say thank you to all our presenters. Just a note from ASCO that today's full presentation will be recorded and for the ASCO YouTube channel, and it will be online soon for those. Thank you to all our presenters, and I'm going to move it on to Dr. Feist to go ahead and close things up for us.
Thank you, Dr. Katu. Thank you again to all the speakers, Dr. Lau, Dr. Young, and Dr. Yoshiyama, for sharing your expertise and experience today. I know we all learned a lot and are looking forward to implementing some of the strategies and educational pearls that we learned from you. Please keep an eye out for an email with the SurveyMonkey link, and take a few minutes to provide us with some feedback from today's program. Thank you again to the OSIF moderators, ASCO Planning Committee, and the ASCO staff for this wonderful event. I hope everyone has a wonderful, eventful Friday and weekend, and thank you again so much.